I'm just so excited to be part of these efforts, and the fact that, people are continuing to tune in about, on lectures for child maltreatment during this time. I can't think of, any more important issue that we're going to, need to attend to in coming months and in the current times during this pandemic, when families are just, risk and vulnerabilities are so increased due to economic issues and social restrictions and such. So thank you all for caring about families and caring about children, and why child maltreatment is a public health problem and why we should take a public health approach to it. I'm a child clinical psychologist, but I started my career after completing my postdoctoral work at the CDC. And so I really got interested in thinking beyond helping the individual and the family, and thinking about how to get prevention programs disseminated broadly so that there's broad access. And so that's some of the things that I will be touching on today. And I'm going to give you two examples of the research that I have going on that takes a public health approach to child abuse prevention and intervention. One example will come from Safe Care. I'll talk about two studies that I've conducted within the context of that intervention. And another will focus on trauma-focused cognitive behavioral therapy and some work that I've been doing in the state of Georgia with victims of commercial sexual exploitation. When we think about public health problems, we think about three things. What is the magnitude of the problem? What is the burden of the problem? And is the problem preventable? And we also think about, can you sort of specifically define the issue that you're thinking about as a public health problem? The CDC, the Centers for Disease Control and Prevention here in the US, has specifically defined child maltreatment really with two varying categories: acts of commission, which includes physical abuse, sexual abuse, psychological abuse, and acts of omission, which captures more of the neglect categories. The magnitude of child maltreatment is vast. In the US alone, we have approximately 678,000 substantiated cases around that annually. And we know that's a significant underestimate because so many children and adolescents do not come to the attention of individuals, child protective services to be able to do investigations. And unfortunately, we have, approximately 1,700 children who die each year from child abuse or neglect in the US. The burden of child maltreatment is vast, and I'm certain we're all aware of that there are increases in health risk behaviors, mental health and social problems that often lead to long-term health conditions. And we see challenges for victims of child maltreatment really across the developmental lifespan in terms of mental health and health outcomes. There's also a substantial economic burden for maltreatment. In the most recent estimate that captured the impact of substantiated child maltreatment cases, the estimate was that $428 billion is incurred annually from victimization. So certainly there's significant magnitude, significant burden for child abuse and neglect. So then we look to the question of, is it preventable? Is it something that we should put efforts behind from a public health perspective? And I hope that we can all agree that the answer to this is a resounding yes. And there are many, many ways we can think to target prevention for child abuse and neglect, really across the social ecological context, from the individual to the relationship to community to societal prevention strategies. The work that I'll present today focuses more on the individual and relationship levels. And so with the public health approach to prevention, the first step is to define the problem, and I shared with you that the CDC has done that. We have the strong definitions for child abuse and neglect. Then do work to identify risk and protective factors, and there's been decades of research on risk and protective factors for child abuse and neglect. Then you move into developing and testing prevention strategies, and then once you understand what works, you work on ensuring widespread adoption. So in thinking about where we might start with prevention of child abuse, the first thing to do is think about what are the two most common forms of maltreatment, and that is neglect and physical abuse. Those are the two most common forms in the United States that are substantiated. Secondly, you want to think about who are the most common perpetrators. And for those types of maltreatment in the US, the most common perpetrators are the children's parents. And our youngest children are most vulnerable, especially children in the first year of life. So thinking about interventions that target neglect and physical abuse, caregivers of young children are programs that could make a real difference. And thinking about risk factors for child abuse and neglect, this is something I'm sure we're all very familiar with. It really, they're the risk factors that increase vulnerability for families and individuals for many, many outcomes. And so the first example that I'd like to share with you is the prevention program of Safe Care, and specifically some research projects that I've run that think about how to expand the reach of Safe Care. So Safe Care, for those of you who aren't familiar with this intervention, is a behavioral in-home parent training curriculum, and it targets high-risk parents with children ages 0 to 5 years. There are 3 modules: home safety, child health, and parent-child interaction. And we use a very structured teaching model across these 3 modules that includes an assess, train, assess approach. So for each module, we want to start with an assessment of the parents with their child and understand which of the target skills they're already doing well, what they've already mastered, and the ones that they may need some additional support and training in. We then move into the training sessions where we use an explain, model, practice, feedback approach. And what this means is that in each session, we're first providing some psychoeducation to parents, trying to help them understand why this target skill is important for child development and for their parent-child relationship. We then model it for them, so we demonstrate for them what the target skill looks like in action. That we then turn it over to them to practice so that they're really learning the skill. And then we offer feedback as the provider to the parent to let them know, what they're doing well and where there may be some additional room for growth. In the last session of each module, we do another assessment to really try and understand what the parental growth has been in those target skills over time. Just a brief overview of the Safe Care research summary to date. In randomized and quasi-experimental trials, we've seen that Safe Care is compared to services as usual in the child welfare system, and this study comes out of the state of Oklahoma, conducted by Chaffin, that the Safe Care intervention leads to reduced child maltreatment reports for families who have had a prior child maltreatment report. In other studies, we've also seen that there are reductions in risk factors for abuse and neglect, such as improved positive parenting skills, reductions in maternal depression, and reductions in child challenging behaviors. Research has shown that Safe Care is satisfying and perceived as culturally competent by the parents who are served with the model. And we've seen, importantly, some similar effects among underserved minority populations, specifically American Indian families in Oklahoma. Safe Care is rated on several evidence-based clearinghouses. One that's shown here is the California Evidence-Based Clearinghouse, where we have a rating of supported, and we have a rating of high relevance to the child welfare system. And so the 2 research projects for Safe Care that I'm going to talk about today focus on this box here, ensuring widespread adoption within the public health model. So Safe Care currently is disseminated fairly broadly in the United States. We're working in over 20 states in the US, and we're working in some countries internationally, including Israel, and we have some pilot work going on in Taiwan and Kenya currently. But there's still a lot of room for broader dissemination. When we disseminate Safe Care from the National Safe Care Training and Research Center, which is in Atlanta at Georgia State University, we go through several phases to ensure a very strong implementation of the model. We go through a phase where we work with an agency that's interested in adopting Safe Care in a readiness process. So thinking about everything you need to do in advance of a workshop to ensure that people have been informed of the model, why the adoption is happening, and that everybody's really on board with the new implementation. We then move into the workshop phase where we actually train the Safe Care providers to deliver safe care to families. We then support those who we train. So those who are trained in the workshops start with families, and we offer support in their initial field work where they're delivering safe care to families by listening to audio sessions and rating fidelity of the sessions, really to be very supportive to the providers and ensure that safe care is delivered as it was designed as it moves into the field. Our safe care providers go through our certification process and then move into a sustained implementation process. And then we offer trainer training for expansion so that agencies can support themselves and not have to continuously come back to the Safe Care Center for training. And we do all this because we know from research on evidence-based practices that when you move from efficacy trials to effectiveness trials, you see a real drop in the effect sizes. So we know that there's a lot other than the intervention itself that impacts, whether this moves into an effective implementation and ultimately impacts family outcomes and child outcomes in the way that you hope that it does. One of my favorite quotes is from Karen Blase, who is part of the FIXIN guidelines on implementation. She says implementation success equals effective intervention by effective implementation. So if you have an effective intervention, but you don't have an effective approach to training people in it, supporting them in it, and ensuring that it's done well in the field, then you're not going to have an effective implementation. So it's like serum in a syringe. Neither is useful without the other. So how do we achieve a public health impact? Safe care has effectiveness and has increasing reach, but many barriers remain to it, being nationwide and having more international impact. And one is certainly the training cost. It's an expensive model to get trained in. Our processes for implementation, even though they do ensure quality, they are often perceived as burdensome and they're costly as well. And we haven't tested, a lot of potential adaptations to new populations that could be really important in the field of child maltreatment. And generally speaking, there are often just challenges within child and family serving systems like high turnover of providers and the complexities of families that can impact an implementation. So the two studies that I'm going to present here today are really trying to address reach and access. And the way that we went about this is that we incorporated some technology into the safe care sessions. And our goal was really to do a couple of things. One was to have the technology deliver some aspects of the safe care program. And the reason for this is that we felt that for every piece of the program that the technology could deliver, that would reduce the training time and cost for safe care provider training and could potentially improve fidelity, because everything that is developed through technology, you can guarantee has fidelity, right? As long as they turn on the computer. We also, though, thought from a parent perspective that some components being delivered through technology could be highly engaging and allow for multimodal learning. If you think about the parents that we're serving today, they've grown up with technology as part of their relationships, as part of their learning. And so I think to remain relevant in human services, we have to think about operating ourselves perhaps in this way. So both of these projects were funded by NIH. One I call Safe Care Tech, and the other is DAD2K. And both incorporate some technology to assist in the delivery of safe care. The target populations are different in the two studies. In Safe Care Tech, the primary population are safe care providers. So we're really trying to understand how does the technology impact the individuals who are delivering the program to families. Whereas in DAD2K, this is an adaptation of safe care that incorporates some technology for fathers. And so they are our primary target population. And you'll see that both studies' designs include mixed methods. And so just a little bit more about the safe care supplemented with technology. The computer-assisted delivery adds some motivational content and then mainly presents that explain and modeling piece of the training sessions. So we do all the psychoeducation, through the technology, and we do some video modeling through the technology. And to show you a little bit how this looks, so the technology is delivered on a tablet. The home visitor or safe care provider brings the tablet to their session with the family, sets the family up with the technology. The parent goes through the technology portion of the session and then moves into some practice and feedback with the provider. So here's just a few glimpses of how the technology looks. So this is a video clip from the intervention. Here's some assessment that's included in the technology delivered intervention. And then this is one screen of the motivational component of just, kind of encouraging parents to get through the sessions. So for the Safe Care Tech project, what we did here was we recruited 30 Safe Care providers, and we randomized them either to the Safe Care Tech condition. So that's, they're brand new providers. They're learning how to do Safe Care. The intervention group learned how to do Safe Care with the technology. The control group just did Safe Care as usual. And we followed these providers over 3 assessments to try and understand, how did the Safe Care Tech impact the job demands of the providers? How did it impact the fidelity of the providers? And was this an acceptable approach to Safe Care delivery from a Safe Care provider perspective? So our hypotheses were that providers in the Safe Care Tech group, or the TASC group, would achieve higher fidelity in Safe Care than the Safe Care as usual group, and that they would have significantly less time burden in delivering the sessions, preparing for, delivering, and the aftermath of sessions. So this is just a little clip of what the Safe Care Takes Care technology program looked like. And I did have a video in there, but that seemed to be the thing that was holding up, being able to progress with the PowerPoint. So I'm sorry that I can't share that with you at this time. This is the demographic breakdown of the Safe Care providers who participated in the study. In all, we were able to recruit 31 providers. When we looked at the fidelity of providers, we found no difference between the Safe Care as usual group and tech-assisted Safe Care group. And this surprised us because we had hypothesized that the technology would lead to higher fidelity, because essentially the Safe Care providers had to do less leadership in the delivery of Safe Care when they had the technology there than when they did not. But that hypothesis was not found to be true. However, when we looked at the breakdown of time, and I know this is a very busy slide, so this next slide summarizes that table, we found that the Safe Care Tech providers spent less time preparing for sessions, less time in delivery of session, and less time in post-session activities. And overall, that the Safe Care Tech saved approximately 3 minutes per session overall. And that was still while achieving high fidelity. We also collected some qualitative information, and we heard a lot of positive things about kind of the technology guiding the sessions, and how it made it, even though we didn't see in the quantitative data that there was higher fidelity for the Safe Care Tech group, the perceptions of the providers was that it made it easier for them to meet fidelity, because the computer, during the computer time, while the parent was doing that, they could kind of review what they had to do for the remainder of the session, and that also prompted a lot of interaction. The providers also really liked the videos. They thought the videos did a really nice job demonstrating the parent and child interactions that were being taught, and that sometimes that can feel a little arbitrary when you're modeling in sessions, so they really liked having that video supplement. And from a family perspective, the providers shared with us that the families really, especially low literacy families, that the videos were very, very helpful and seemed to prompt more discussion about the target skills than in the Safe Care as usual. So what we learned from this study is that tech-assisted Safe Care is feasible. From the quantitative data, we learned that there were no differences in fidelity between the two groups, but there were some lower time differences in prep and delivery in favor of tech assisted. And then the qualitative data suggested that the tech is feasible and acceptable, and that it can be helpful for new trainees and especially for parents with low literacy. Of note, like in the current times, in the pandemic we're currently experiencing, we've had to move Safe Care fully to technology delivery, as I'm sure many mental health and home visiting programs have. And we have some best practice guidelines on our website for this, and we've been able to utilize some of the videos that we created during this grant to supplement Safe Care and help out during this time when it's just been so difficult to do kind of services as usual. So moving on to the Dad2 case study, and this is really, again, in thinking about increasing widespread adoption, you want to be thinking about populations that you haven't been able to typically reach, and that's certainly the case for fathers. So we wanted to understand what's the feasibility of Safe Care Parent-Child Interaction module, which we rebranded as Dad2K, or the Dads 2 Kids program, for purposes of this trial. And we wanted to essentially demonstrate that Safe Care would be an acceptable intervention for fathers and demonstrate initial efficacy of the program. And why is this an important adaptation? Well, fathers are certainly involved in the perpetration of child maltreatment, child physical abuse, and neglect, and they are most often the perpetrators of abuse that leads to child fatality. On the flip side, fathers are super important to the lives of their children, and having positive relationships increases a variety of positive outcomes for youth throughout their life. So we thought it was just an incredibly important population to focus on. So our inclusion criteria for this project were that we recruited dads who were at least 18 years old and had a child between the ages of 2 and 5 years old. And that's because we implemented the parent-child interaction module, which is a curriculum specifically for the 2 to 5 year old population. We have a parent-infant interaction and a parent-child interaction. And so we focused on the parent-child interaction for this study. We recruited English-speaking fathers, and we looked for fathers who had at least 2 risk factor criteria for child physical abuse or neglect based on the literature. The dads that we recruited were 99 dads living in Atlanta. 91% were African American. The mean age was 30. About 59% had either a high school education or less. And it was a very impoverished population, with more than 70% making less than $25,000 annually. For the augmentation of the Safe Care for Fathers, we focused on the parent-child interaction module, as I explained earlier. And the reason that we did this is that the full Safe Care program is 18 sessions. And we did some focus groups, and we learned from fathers that seemed to be too many sessions. They just did not think they could commit to that length of a program, but that 6 sessions, which is what each of our modules is in length, was a reasonable ask. And so we looked at our 3 modules: parent-child interaction, health, and safety, and we talked to fathers in the focus groups about which module was most consistent with the kinds of skills that they used in their families and in their daily interactions with their children, and the parent-child interaction module fit best. We also incorporated technology for the reasons that I shared earlier, but also because what we learned from fathers in these focus groups was that they really didn't want to sit and talk to a provider one-on-one for a long time. They wanted some things that would break up the session and sort of take the pressure off all that verbal communication. We also incorporated a co-parenting module because we thought that was incredibly important to not sort of disregard the importance of, for the fathers who are co-parenting, building up the skills for both parents so that there would be consistency of the parents' expectations with their children. So this is what the Dad2K technology component looked like. Here are the videos. This was our Coach Jerome. We did sort of a basketball theme for Dad2K, and so Coach Jerome gave all the explanations, and then we had a father Brian, who did all the modeling with his young son of the skills. And for the control group, they just received some positive parenting materials in the mail. So this was a very, kind of conservative trial. The topics of the materials included things like developmental milestones, strategies for toilet training, 100 ways to praise, so forth. And the measures that we included were the CPAT checklist, which is an observational measure from Safe Care that focuses specifically on the 10 skills that fathers learn in the parent-child interaction module. And then we explored some outcomes related to father mental health, as well as child maltreatment behaviors from the parent-child conflict tactics scale. So we also completed a qualitative component of this study. There's such little research on fathers participating in parenting programs. We thought this would be incredibly important. And so we had a wonderful PhD student who is getting his degree in PhD in sociology, and he led the 25 qualitative interviews for the project. So study findings on the CPAT, which again is that observational measure of the 10 skills taught in the parent-child interaction module, we did see a significant improvement of fathers in the Safe Care group. So they were they were demonstrating about half of the skills at baseline, and at the end of the 6 sessions, they were doing about 9 out of the 10 skills, or 90%. So we were really excited to see that. On the father-child maltreatment risk behaviors, however, we did not see significant differences emerge between the DAD2K group and the control group, the corporal punishment subscale or the neglect subscale. And we really had a lot of measurement issues on this particular measure. Almost all fathers at baseline and at follow-up noted 0, that they had no problems in these areas. This was a very marginalized population that isn't often included in research. And so it's just, we just really didn't have a lot of understanding about what measures would be useful with these fathers. And so clearly, this sort of indicates the importance of having multiple types of measures, including observations, because without those observational measures, we wouldn't have really understood, if there was an impact of the program at all. Our qualitative findings showed that fathers really did learn a lot from the DAD2K program, that they learned things about praising, they learned ways to interact with their children, and that they reported incorporating these skills into real life. So we were excited to hear about these things, about really the changes in parenting knowledge that these fathers had. We also asked the dads specifically about parenting skills, and they, just without any direction, and the questions, very open-ended questions, the fathers really could feed back to us those parent-child interaction skills that we teach in Safe Care, and could give very strong examples of ways that they have implemented them into their day-to-day lives. And so we were really excited to hear that from the fathers as well. And probably my favorite quote from the whole intervention group was the father who said, "I feel like the DAD2K program helped me develop as a father. And it helps me talk to my kids more and do more activities and stuff with them and learn how to discipline them without just whipping and yelling at them. Just the little things." I think those are really the huge things, and I think this was really exciting to see how much the fathers engaged in the program and seemed to learn from the program. Another thing to note is that in this study, the dads had very, comparable completion rates to that of mothers in Safe Care. So they were right around the 50th percent mark of completion, which, none of us knew at the start of this trial whether fathers would really engage. So we were very excited about that. We also learned that there was high satisfaction with DAD2K, that the intervention fathers exhibited behavioral change on the father-child interaction, but we did not see differences on the self-report child maltreatment measure. And we have a variety of things that we hope to continue in this line of research. But one thing I'd love to note is there's going to be an Oklahoma agency that begins implementing safe care, or Dad to K rather, this spring. So we're super excited about that moving forward. So now I would like to switch gears to another example of a project that I'm working on that's taking a public health approach to the mental health intervention for youth victims of commercial sexual exploitation, which is a type of maltreatment. And I am very sensitive to the time, and so I'm going to go through this example fairly quickly, and I'll be happy to take questions at the end. And sorry that the opening of the presentation was slow to get started. So for those of you who haven't learned much about sexual exploitation to date, it is a specific type of sexual abuse of children and youth that involves the exchange of something for sex or sexual acts. Anything can be exchanged: money, drugs, shelter, protection. The sexual acts include a wide variety of things that can be coerced in this way. Some good news regarding policy is that for a long time, commercial sexual exploitation was considered child prostitution. And thank goodness that's no longer the case for most of our country because of the Safe Harbor Act, which moved to child prostitution to something that could not be prosecuted and should be assumed as an act of child sexual abuse for individuals involved in this under the age of 18. So when you think about a public health approach to CSEC, we are much earlier in our public health approach to this particular type of maltreatment as compared to child physical abuse and neglect. We are really still defining the problem, identifying risk and protective factors, and we're just starting to develop and test prevention strategies for this type of child sexual abuse. It's very difficult to understand currently what the magnitude is of this type of sexual abuse, because it is inherently challenging because of the covert nature of trafficking or commercial sexual exploitation to have clear screening procedures that gives us, kind of the true numbers. But we do know for the youth that have been identified that there is substantial burden in terms of health outcomes and mental health outcomes, as well as unplanned pregnancy and STIs. We're learning more about the risk and protective factors for CSEC. Foster care youths, especially those who have unstable placement issues, seem to be especially vulnerable, as are youth who have extensive child abuse or violence and trauma in their childhood. Youth who run away are often at risk as well. And we also are hearing more and more about our LGBTQ youth and the risks that they are put at for this particular type of victimization. I've recently finished a publication on the risk factors for CSEC in Uganda from a project there that was led by Monica Swan, and this was published in the Journal of Interpersonal Violence. And ultimately, the risk factors that emerged were being female, ever living on the streets, ever experiencing dating violence, experiencing prior rape, and social media use was a very strong indicator of CSEC risk. And we did see some different risk factors according to gender, with boys, the two most prominent risk factors being living on the streets and a history of rape. And for girls, it was much more broad. So it was, the prior trauma experiences, alcohol use and social media use, and parental factors such as parents on alcohol use and their attitudes towards sex. So coming back to Georgia, where I'm doing this work currently, we've been thinking a lot about where do we start with intervention and prevention efforts for CSEC youth. Atlanta is a hub for CSEC, and recidivism is very common. So a lot of youth will be identified as CSEC, pulled out of the life, end up running away from their placement and back in the life. So there's a lot of back and forth, kind of similar to a substance abuse sort of model or framework. And Georgia does have an existing system of care, but it was really lacking effective mental health services as part of their system of care. So we wrote a grant to the National Child Trauma Stress Network, which is part of SAMHSA, to develop Project Intersect. And really our goal was to identify mental health interventions that could be broadly disseminated and evaluated with CSEC youth across the state of Georgia. We ended up selecting trauma-focused cognitive behavioral therapy because it was really commensurate with a lot of the symptomatology that CSEC youth were demonstrating when they kind of showed up for mental health treatment, and of course because it has got a lot of research supporting the model. So we thought, let's try to start with TFCBT and let's see how we might adapt it or augment it to be more comprehensively effective in serving CSEC youth. So what we've accomplished to date is that we've trained over 100 therapists in TFCBT in Georgia, and we've trained across a variety of treatment settings, residential settings, community settings, and so forth, which is incredibly important because the youth do not tend to have stable placement, so they just kind of end up in a lot of different settings, and we thought if we could have therapists, trained, effective therapists in a variety of settings, that would be the most helpful. And we've created a web page that allows child and family serving brokers to find TFCBT therapists. So child welfare, juvenile justice, hospitals, whomever would need to make a referral for a CSEC youth for mental health issues can go to our website and do a find a therapist search and see what therapists are trained in TFCBT in their area. So when we trained these therapists in TFCBT and we have, and they've gone on to serve CSEC youth, they've pretty consistently shown high acceptance of TFCBT across a variety of categories. They like using TFCBT. They believe it's an effective approach for youth. They believe they have the materials they need to effectively serve the clients, and overall believe that TFCBT is an effective intervention for CSEC. The two areas where we've seen, some not dissatisfaction, but need for improvement is one in being a beneficial model for the caregivers of CSEC youth and for the broad-based challenges beyond the mental health symptoms of CSEC youth. So those are some areas that we've spent a lot of time building around additional trainings for this group of therapists in order to sort of make it the most effective as possible. Now, what we're learning from these youth, we have a very comprehensive just program evaluation for youth that are served by the therapists that we've trained to date. And so we have a baseline battery and a battery that we deliver at graduation of therapy to just try to learn more about the trauma history, demographics, and mental health symptoms of these youth. So what we've learned to date from the 106 youth that have completed the evaluation is that they're primarily female. In our sample in Georgia, they're primarily African American, followed by Caucasian. On average, they have a number of 6 traumatic events in their childhood. And so this is in addition to the CSEC experience. So this is a highly traumatized group. And about 40% of the youth are reporting full PTSD symptomatology. When we look at our youth completers, which we have a very small number of completers to date, 28, but what we are seeing is that if you look at figure 1, there's a significant drop from the start of treatment to end of treatment in the PTSD symptoms. And if you compare our COINS-D for Project Intersect to the existing TFCBT literature, the COINS-D are comparable. So we really do think that this is an effective intervention for youth if you kind of think about benchmarking from these prior studies. And so it seems to be, a viable approach for serving the mental health needs of these youth. So we'll be continuing this program evaluation over the next year with CSEC youth who participate in TFCBT. We're currently working on some publications from the baseline data of those 106 youth to really just understand what are some predictors of the different clinical presentations for treatment. In addition to PTSD, we included BASC, the BASC measure as well. So we have some internalizing, externalizing outcomes as well as substance use. And as we have more completers, we want to learn more about predictors of engagement and retention in treatment. So conclusions and lessons learned, it's a very exciting time in public health research to focus on child maltreatment and trauma and think about how to move us along the public health model to, you know, the widespread adoption of effective programs, which is really what my passion is as a child maltreatment researcher. We've also learned that applied research, you know, getting out there and doing these implementation science-based studies, they're incredibly important, but they're also very difficult because you're often having to recruit not simply just the individual client, you're often recruiting agencies, and your research studies often require that there's a successful implementation of the intervention to be able to test it. And so it's just, there's so many layers to it. It's very exciting. It feels very real, but it's also very complex. Mixed methods have been a key in the research that I've conducted to date, and in both of my studies, especially DAD2K, we would have known so much less about the, you know, potential efficacy of that intervention if mixed methods hadn't been included. And I really do believe that we have the opportunity to achieve a public health impact on child maltreatment. And I hope that, you know, these studies leave you with some hope that, you know, kind of we're moving in a positive direction there. So I'll stop now for questions, and I do have some relevant references from the project as well, and my contact information.
Shannon, thank you so much. I think that you really remind us how instrumental research is for all of we clinicians who are going and doing it in the field beforehand. So thank you for that very much. Christina, are you there?
Yeah.
Hi. We've already got one question on the chat, so I'm going to hand this over to Christina. And if anybody else would like to ask, you're more than welcome.
Would it be okay if I stop the share now so I can see the video?
It's really a good idea.
Okay, doing it now.
Okay.
All right,
Thanks.
so the first question we have, for the DAD2K videos, why did you choose a basketball coach theme to deliver the information?
Great question. So if you ever do any development of interventions, make sure that when you do that you do it in conjunction with the community of participants that you hope to include in research. So we did focus groups and we did individual interviews with fathers from the communities where we were going to be recruiting from to decide on exactly how to design the technology based approach and the themes. And actually the reason that we ended up with Dad2K or Dads to Kids as our sort of name for the program was because the fathers were all at that time really in love with this game called NBA 2K. And they thought, ooh, Dad2K will kind of be like, you know, sort of branded kind of like that, and it'll get people excited about participation. So, so yeah, learn from the communities you hope to serve.
Very smart. Yeah, 2K is still such a huge thing. So the next question we have is, how do you explain the reactions of the dads that they've become more sensitive to their kids on the one hand, and at the same time, the maltreatment rates did not go down?
It's a great question. And I think we have much more research to do with fathers to really understand more about these complexities. I mean, I honestly think that we don't have good measurement available for fathers, especially marginalized fathers at this time. These were men who had, you know, extensive criminal histories, had, you know, even though we did not recruit from the child welfare system, they had often had experienced child maltreatment reports, and they were not men who had participated in other research studies. So I honestly, at baseline, I think they were like, I'm signed up for this to try and, you know, see what this is about and get this incentive. But I don't know if I trust these people, that this consent form where they really say they're not, you know, they're not keeping identifiable information and all this. I just don't know that that was communicated as effectively as it could. And, I think over the course of the study, the men who stayed in, I think really did build more trust for us. And those qualitative interviews happened at the end of the project. And it seemed like there was a lot more honesty in those interviews than in the quantitative data. So I think that it possibly was a story of poor measurement and need for better trust between the communities that we want to learn from and researchers at universities.
Thanks for coming today and sharing all of these great research projects with us. I think it's very impressive that there are people who are so committed to ending maltreatment the way that you are furiously working at in your lab. And thank you so much for coming today.
Thank you. And same to you, Paula. I know your heart is in this work as well. And thank you all for